Hi everyone and welcome to our module on pharmacokinetics 2. In this module, we're talking about the second aspect of pharmacokinetics, which is on the component of metabolism and excretion. We've already talked about the first three components of pharmacokinetics. Those components include administration, absorption, and distribution. To briefly introduce what pharmacokinetics is defined simply as the fate of the drug within the body. Simply put, we can define pharmacokinetics as what the body does to the drug. And I gave the example of paracetamol being used. Typically, when you use the paracetamol, it's usually in a tablet form. And after using it, after taking it or introducing it into the body, how that paracetamol is excreted out of the body through the urine or through bile is not the same way in which it was initially taken, meaning that the body has altered the structure of the paracetamol. And the alteration that the body does to a drug is what we call pharmacokinetics. There are five major fates of pharmacokinetics. These fates include administration, the absorption of the drug, distribution of the drug, metabolism, and excretion. I will be focusing on the remaining two in this model. This picture shows a snapshot of the entire component of pharmacokinetics, and we can remember the component of pharmacokinetics with the acronym ADME. A there stands for administration and absorption, and that's just the introduction of the drug into the body, and then the movement of the drug from the site of introduction into the bloodstream. The D there stands for distribution, and that's the widespread delivery of the drug to various organs of the body. The M there stands for metabolism, which is the breakdown of the drug, and then the E there stands for excretion, which is the removal of the drug from the body. Now, before we go ahead to talk about drug metabolism and excretion, it's important to note that the combined terminology of metabolism and excretion is referred to as elimination. And elimination, simply put, is just the removal of the medication from the body. The removal could be in the form of the conversion of the drug to a metabolite, which is metabolism, or the actual removal of the drug from the body, which is excretion. We'll talk about metabolism and then excretion in the next couple of slides. Metabolism of the drug refers to the biochemical modification of the drug. The key word here is biochemical modification, and it occurs at specific sites of the body, which we'll see. Um, the important thing about metabolism is the fact that the drug tends to be converted into hydrophilic metabolite, and this hydrophilic metabolite that the drug is converted into makes it to be easily excretable. Now, the key thing to note about metabolism is the fact that for a drug to be excreted out of the body, that drug would need to undergo metabolism. And the idea of metabolism is to make a drug to be polar or hydrophilic, and it is easily removed from the body. The sites of drug metabolism are numerous, but the commonest site of drug metabolism is the liver. Other sites of drug metabolism includes the kidneys, the small intestine, and then the lungs. When a drug is metabolized, the outcome of metabolism could go in either four ways. Either we have an inactive drug being given, and after metabolism, that drug becomes activated, or we have an active drug being given, and then after metabolism, the drug becomes inactive. It's also that we could have a drug that is initially active, and after it has been metabolized, the metabolite is still active, and then finally we could have a scenario where a drug is initially active, and after metabolism, it becomes toxic in terms of its metabolite. The commonest out of these four outcomes tends to be the conversion of a drug from its active form to an inactive metabolite. Here's an example of a drug, a typical example of a drug that is metabolized, initially being inactive, but after metabolism becomes active. The drug in this case is levodopa. Levodopa is a drug used in treating Parkinson's disease. And as you could see on the left side of the screen, levodopa is metabolized using the enzyme dopa decarboxylase, and is converted into the metabolite dopamine. Dopamine is the active form of this particular drug, and it's the drug that is the particular form that will be working doing the function of treating Parkinson's disease. The L-DOPA aspect is an inactive substance or a precursor substance, and it needs to be metabolized for it to become active in the body. So this picture depicts for us a drug that is metabolized from an active form to an inactive form. The drug in this case is epinephrine. Now on the left side of the screen, you will see that epinephrine could be metabolized into beta-nephrin or vanillin acid. And there are two major enzymes involved in metabolism of epinephrine. You could have metabolism by catechol O methyltransferase enzyme or monoamine oxidase enzyme. And either of these enzymes would form a metabolite that is typically inactive and is easily excreted through the kidneys. Picture shown here shows an example of a drug that is metabolized from an active form to an active metabolite. And the case, or in this case, because of this picture, we could see the drug codeine being metabolized using the reaction dealkylation. After the alkylation of codeine occurs, the metabolite form is morphine. Morphine is also an active substance, and we go from an active substance, which is codeine, to an active metabolite, which is morphine. And this is the reason why some individuals that are addicts to morphine and are not able to afford morphine could get codeine, overdose on codeine, and what is expected to happen is that the codeine is converted to morphine, and the morphine will do the psychoactive effects that the user is intending for it to do. Finally, we have an example of a drug that is metabolized from an active form to a toxic form. The drug here is Panadol or paracetamol. The steps in metabolism of paracetamol are very complex. On one of the steps, a metabolite that is formed tends to be very toxic to the body. And hence, the reason why an overdose of Panadol or paracetamol could be toxic to the liver and could damage the liver. For drugs to be metabolized in the body, they need to go through two major phases. Phase one reaction involves the initial conversion of a drug to a slightly polar substance, and then phase two reaction involves the conversion of the drug to a completely hydrophilic substance which can be excreted from the body. Phase one reaction is also called functionalization reaction, and the reason why it's called functionalization reaction is because of the fact that what goes on in this type of reaction is the addition or unmasking of a functional group. So functional groups within the drug could be unmasked, or if they are not present within the drug, they could be added or introduced into the drug. And the point of this addition or unmasking of the functional group is to make the drug to be slightly polar than it already is. The enzymes responsible for the phase one reaction that we see in drug metabolism are typically called cytochrome P450 enzymes. They are enzymes that are typically found within the smooth endoplasmic reticulum. And these enzymes are numerous within the liver, hence the reason why the liver is one of the primary sites of metabolism. These are the examples of phase one reaction. We have oxidation reaction. Oxidation reaction is a type of phase one reaction that makes use of the enzyme cytochrome P450 oxidase as well as the hydrogenase enzyme. We have the phase one reaction, another example being reduction. Reduction reaction makes use of the enzyme cytochrome P450 reductase enzyme and the decarboxylase enzyme. And then finally, we have the last type of phase one reaction called hydrolysis, which makes use of the enzymes esterases and amidases. Note please, some of these enzymes could be microsomal or non-microsomal, and it's important to note which are microsomal, which ones are not. Oxidation reaction, for example, the cytochrome P450 enzymes are typically microsomal. The hydrogenase enzymes are non-microsomal. For reduction reaction, cytochrome P450 reductase tend to be microsomal, and then the carboxylase enzymes are non-microsomal. And then finally, both the amidases and the esterases are non-microsomal enzymes. So alcohol is one example of a drug that can be metabolized using the phase one reaction. And alcohol tends to be metabolized using the oxidation reaction in phase one. And to make use of enzymes like the cytochrome P450 oxidase or the dehydrogenase enzymes. The example shown here is levodopa. Levodopa is a typical example of a drug that is metabolized also in phase one, and the type of metabolism it goes through is a reduction reaction. The enzyme responsible for the metabolism of levodopa is a decarboxylase enzyme. And finally, we have the picture here depicting a local anesthetic agent. Local anesthetic agents could either be an amide or an ester. And this is also metabolized using the phase one reaction, particularly using hydrolysis. The enzymes responsible for metabolizing this local anesthetic agent would be amidases and esterases. Hence, the reason why the drugs are typically classified as either an amide or an ester. Phase two reaction is also called conjugation reaction, and Phase 2 reaction is typically referred to as the most important of the two phases of drug metabolism. The reason being is that a drug that goes through phase 2 reaction automatically becomes hydrophilic and is easily excreted from the body. For phase 2 reaction to occur, an endogenous substance will be added to the drug to make the drug to be hydrophilic. This is in contrast to phase 1 reaction, in which we have a functional group being added on max on the drug, which just makes the drug to be slightly polar. In phase 2 reaction, endogenous substances are added, and then at the end of the day, the drug becomes hydrophilic as a result. The examples of phase 2 reaction are numerous. The examples of phase 2 reaction include the glucuronidation reaction. In this case, we're adding glucuronate or glucuronic acid as the endogenous substance. The enzyme responsible for this particular type of reaction is glucuronil transferase enzyme. This enzyme is usually referred to as the microsomal enzyme. Then we have the acetylation reaction, which is the second type of phase 2 reaction. This involves the addition of the endogenous group acetate onto the drug. The enzyme responsible for this particular reaction is N-acetyltransferase enzyme. Then we have sulfation reaction. Sulfation reaction, a sulfate group is added, and the type of enzyme responsible for this type of reaction is the sulfotransferase enzyme. Both the sulfotransferase enzyme and the N-acetyltransferase enzyme are both non-microsomal in their function. They are non-microsomal enzymes. Then we have the methylation reaction and the other three, the glycine conjugation and then the glutathione conjugation. These enzymes are all non-microsomal enzymes. For methylation, we make use of methyltransferase enzyme. For glycine conjugation, we make use of glycine conjugates. And for glutathione conjugation, we could make use of glutathione conjugates. And these enzymes, they are all adding an endogenous substance to the drug. For methylation, the endogenous substance being added to the drug is methyl. For glycine conjugation, the endogenous substance being added to the drug is a glycine, an amino acid. And for glutathione conjugation, the endogenous substance being added to the drug is glutathione. Just examples of each of the different reactions in phase 2 drug metabolism. The drug shown in this particular picture is chloramphenicol. Chloramphenicol is an antibiotic that is used in treating different infections. It's typically metabolized in the phase 2 reaction, particularly through glucuronidation. So it makes use of the glucuronil transferase enzyme in doing its metabolism. Isoniazid is an example of a drug that is metabolized also in phase 2. Isoniazid is typically metabolized using acetylation, and it involves the transfer of an acetyl group to isoniazid as a drug. The enzyme responsible for this is acetyltransferase enzyme. It's very important to also note as a side to isoniazid and the metabolism of isoniazid that we could have issues with genetic differences in the metabolism of isoniazid, where people could have slow activity or fast activity of acetyltransferase. Hence, we could have slow slow metabolism of isoniazid or fast metabolism of isoniazid. So you have people that are slow acetylators and people that are fast acetylators, and this is purely based on genetic makeup. Morphine could be metabolized using sulfation reaction, and this just involves the addition of a sulfate group to morphine. The enzyme responsible for this particular type of reaction is the sulfate transferase enzyme, as we've seen in the previous slide. And the point is to make morphine to be more easily excretable. In a nutshell, this describes drug metabolism. Remember that drug metabolism involves two major phases. Phase 1 is the conversion of the drug to a slightly polar substance, and this involves the addition of a functional group. Like I said, there are three major types of phase 1 reaction. It's the oxidation reaction, the reduction reaction, and the hydrolysis reaction. Then we move into the phase 2 reaction, which involves the addition of an endogenous substance to the drug, and this makes the drug to be completely hydrophilic. These drugs that have undergone a phase 2 reaction is easily excretable as a result. The types of phase 2 reaction are numerous. Examples include chloridation, acetylation, methylation, and so on and so forth. What are the factors that affect drug metabolism? There are numerous factors affecting drug metabolism, and what this entails are different conditions or states that could either increase or decrease the level of metabolism within the body. And these factors could be anything from age. The age of a patient could affect metabolism. Usually, individuals of extreme age tend to have reduced metabolism. And when we move beyond the extreme of age and we start to have an increase in age, metabolism tends to rise from there. So children and elderly people tend to have reduced amount of metabolism, and this is by virtue of the fact that the enzymes within the different sites of metabolism are not fully developed or are poorly present within those individuals of extreme ages. But as we age increase, as we go from infancy to childhood to adulthood, the level of metabolism or rate of metabolism would increase as a result. Underlying disease is also a factor affecting metabolism. Imagine a scenario where those sites of metabolism are diseased or affected. Like for example, if someone having liver cirrhosis or liver damage, the liver being a common site of drug metabolism, because of its disease state, metabolism would be affected, and then the rate of metabolism of the drug would be reduced. Gender could also be a factor affecting drug metabolism. Typically, males tend to have greater rate of metabolism than females, and this is by virtue of the fact that the enzyme levels present within the male is different from female, alongside the fact that there's also different hormonal balances that influence metabolism. Nutrition could be a factor affecting drug metabolism in the sense that a patient that is malnourished or not well nourished would have very little amount of protein and amino acids, and those amino acids are required for the formation of enzymes. So, malnourished in the malnourished state, there's reduced production of enzymes, and those enzymes are not going to be available to metabolize the drugs within the site of metabolism. Genetics could play a role in affecting metabolism. As we saw with isoniazid as the case study, you could have a scenario where the enzymes that are metabolizing a particular drug could differ in terms of their rate of action based on genetic makeup. You could have people that are slow acetylators or slow or fast acetylators of a particular drug, and hence these drugs are have reduced or increased metabolism just based on genetic makeup. And finally, drug interactions could be a factor affecting drug metabolism. We'll talk about this in a separate module. Excretion is the final component of pharmacokinetics, and it is defined as the removal of drugs or its metabolites from the body. Remember that elimination is a combination of both excretion and metabolism. After metabolism occurs, the drugs and its metabolites will be removed from the body through the process of excretion. We have numerous sites of drug excretion in the body. The common ones include the kidney. The kidney is the commonest site of drug excretion. Then the liver, also the salivary glands, the eyes, the lungs. The skin could be a site of drug excretion. The breast, the intestine, and the head. The reason why these sites are actually sites of drug excretion is because if you pay attention, these sites are actually places where secretions are actually formed in the body. For example, the kidney is involved in the production of urine, the liver is involved in production of bile, the breast is involved in production of breast milk, the intestine produces fecal matter, the air, for example, produces sebum. So each of these sites have particular secretions that they are involved in producing, and it's through the production of these secretions that drugs are excreted out of the body. The kidney is the commonest site of drug excretion. And remember that as the site of drug excretion, it's going to be involved in the production of a particular secretion. That secretion will serve as a medium to carry out the drugs from the body. In the case of the kidney, the medium of excretion for the kidney is urine, which you can see on the left side of the screen. For the liver, being the second commonest form of excretion, the particular medium by which the liver helps the body in removal of drug is bile. So bile production is the process by which drugs are being removed from the body by the liver. It's important that we note about the mechanism of drug excretion. Now, due to the fact that we have a number of sites of excretion, we would also have different mechanisms by which the sites tend to excrete drugs. Starting with the kidney being the commonest site, remember that the kidney would excrete drugs using a particular medium that it uses, being urine. Hence, the mechanism of renal excretion is similar to the mechanism of urine production. And from your physiology, remember that the mechanism of urine production entails three major processes. First would be glomerular filtration, whereby blood within the vessels of the kidney are filtered into the glomerulus. Then there's tubular secretion, drugs and present within the blood would also move from the vasa recta into the renal tubule. And then finally, we have the tubular reabsorption, which is the process of movement of content or drugs from the renal tube back into the bloodstream. Now, it's important to note that out of these three mechanisms, the ones that promote renal excretion are the first two. Glomerular filtration involves the movement of a drug from the bloodstream into the glomerulus, and renal secretion also involves the movement of blood from the bloodstream into the renal tube. Tubular reabsorption, on the other hand, tends to reduce renal excretion, and this is very important to note that we don't want a scenario where the drugs are going back into the bloodstream from the renal tube. We want them to remain in the renal tube and be excreted out as part of the urine. For hepatic excretion, the mechanism would mirror the production of bile. So the production of bile contains two major processes. We have hepatic secretion within the liver, and then after the bile has been secreted by the liver, it would flow through the biliary tract, enter into the GIT, and while passing through the GIT, it is reabsorbed back into the bloodstream in the process we call enterohepatic circulation. So this is the entire process of bile production and flow. And this it would be the way in which drugs are also excreted from the body. It's important to note that hepatic secretion tends to drive hepatic excretion, whereas enterohepatic circulation tends to prevent um, hepatic excretion. So we don't want too much enterohepatic circulation to be occurring, and that would hamper or impair the excretion of drugs through the liver. For the salivary gland, the mechanism of salivary excretion is primarily through the process of passive diffusion. And drugs that usually make use of this mechanism are basic drugs like phenytoin, like diazepam, drugs like theophylline, and drugs like caffeine and lithium. These are drugs that are typically excreted using the salivary excretion mechanism. For the lungs, the mechanism of pulmonary excretion is a mechanism that involves two major processes: the process of passive diffusion and the process of expiration. So, if a drug is going to be excreted by the lung, the drug will first of all pass through the process of passive diffusion to diffuse from the bloodstream into the alveoli, and then from the alveoli, that drug is going to be expired out through the respiratory tract. Examples of drugs that are typically excreted through the lungs are inhalational anesthetic agents. For the eyes, the mechanism of tears excretion typically would follow the mechanism of passive diffusion, and drugs that tend to make use of this mechanism are usually lipophilic, non-protein bound, and non-ionized drugs. And a very common or typical example of a drug using this mechanism is cytarabine, which is an anti-neoplastic agent. For sweat glands of the skin, excretion through this particular mechanism would also make use of passive diffusion, and examples of drugs that could be excreted through the sweat would be alcohol, antipyrines, benzoic acid, cocaine, salicylic acid or aspirin, lead, and then mercury. These are examples of substances and drugs that are excreted through the sweat. Excretion through the air would involve the production of sebum. The air will produce sebum through the sebaceous gland, and the mechanism by which drugs are excreted through the air tend to be unknown. However, there's a theory that it could be due to deposition from the capillaries. Regardless, the examples of drugs that are excreted through this mechanism are very few. So we have drugs like phenobarbital, methamphetamine, and methoxyphenamine. These are examples of drugs excreted through sebum. Then the excretion of drug through the breast also follows the mechanism of passive diffusion. The breast will be involved in production of breast milk. Through the process of production of breast milk, drugs could be secreted into the breast milk through passive diffusion. And a typical example of a drug that makes use of this mechanism is aspirin. What are the factors affecting drug excretion? So this will be factors that would either increase or decrease the rate of drug excretion. First on the list would be the pH, and this includes both the pH of the drug and the pH of the excretion medium, whether the excretion medium is the urine, whether it's bile, whether it's sweat. The pH of that medium and the pH of the drug would work hand in hand to either increase or decrease excretion. We'll talk more about pH, but what you need to remember regarding pH is that contrast with what we have with drug absorption, the golden rule for pH and drug excretion is that weak acids are better excreted in a basic environment, whereas weak bases are better excreted in an acidic environment. I'll explain that in the next slide. Another factor that can affect drug excretion would be the lipid solubility of the drug. And it's just very important to note that drugs that are highly lipid soluble have reduced level of rate of excretion. Drugs that are largely water soluble are drugs that are easily excreted from the body. And remember that metabolism is there for the purpose of making drugs to be hydrophilic, to be water soluble. And once these drugs are made water soluble, they are easily excreted. So the lipid solubility tends to prevent or reduce drug excretion. Another factor that could also reduce drug excretion is enterohepatic circulation. I talked about this while talking about the process of bioproduction. Enterohepatic circulation would allow drugs to be shuttled from the GIT back into the bloodstream, thereby the amount of drug that is excreted through the fecal matter will be reduced. The drug size also tends to influence drug excretion in the sense that the smaller the drug, the more the chances of the drug being filtered, or the more the chances of the drug being undergoing passive diffusion and being secreted into the medium of excretion. So small drugs tend to have tend to be better excreted. Larger drugs, on the other hand, find it harder to enter into the site of excretion, and the rate of excretion will be reduced for larger drugs. Protein binding also tend to affect drug excretion. Drugs that are tightly bound to protein would not be released easily, and as a result, these drugs will remain in the bloodstream. So the higher the protein binding, the lower the drug excretion. Renal disease could affect excretion. Remember that the kidneys are the commonest site of drug excretion. So if the kidneys are defective, the rate of excretion of many drugs in the world would be affected. And then finally, drug interaction could also be a factor affecting drug excretion, and we'll talk about this in a separate model. And this picture captures the concept of pH in relation to drug excretion. Remember that when we have a drug that is placed in an environment, once that environment has a pH that is opposing to the pH of the drug, that drug becomes ionized. So we could have a form of an acid that is either ionized or unionized. The unionized form, the acid is the Ha form, whereas the ionized form is the A minus form. If this particular acid is kept in a basic environment, what happens is that the acid goes from the drug that is a weak acid goes from the unionized form to the ionized form. And this ionized form of the drug would allow or enable the drug to remain in the site of excretion, to remain in the renal tube. It was the kidney we're talking about. Hence, it promotes excretion as a result. If that drug was kept in an environment that has the same pH as the drug will remain in its unionized form, the HA form. And in its unionized form, the drug could easily cross through the um, barrier and enter back into the bloodstream. And as a result, this would reduce drug excretion. Remember that if we're talking about the kidneys, we want to have tubular secretion and glomerular filtration. We want to avoid tubular reabsorption. And one thing that might promote tubular reabsorption would be if the drug is in its unionized form or non-polar form. Easily that drug can cross from the renal tube back into the bloodstream. This also goes to the same. This also is the same thing for basic drugs. So weak base, typically when placed in an acidic environment, will be converted into their ionized form, and in their ionized form they remain in the renal tube, or they remain in their site of excretion, and they are easily removed out of the body. If they are placed in an alkaline environment rather, these drugs would be remaining in their unionized form, and if they are stuck in their unionized form, they could easily cross from the renal tube into the bloodstream. So we want drugs during excretion, we want drugs to remain in their ionized form, and in their ionized form, they are easily excreted out. So that's why the golden rule states that weak acids are better excreted in basic environments, and weak base are better excreted in acidic environments. So let's try out this case study. Science students from the University of First Choice and Nation's Pride overdose on codeine, which is a weak base, in the early hours of today. His roommate called you, who was a medical student, to request for assistance for managing him. In order to increase the excretion of the drug from his body, what step would you take? A, would you like to acidify the urine? B, would you like to alkalinize the urine? Now, this particular question just tests our knowledge on the relationship between the pH and drug excretion. I remember that the golden rule states that weak acids are better excreted in the basic environment, and weak base are better excreted in an acidic environment. Because this particular individual are taking a drug that is a weak base, what we want to do to increase the excretion of this drug by manipulating the pH is by acidifying the urine. So we want to acidify the urine. And what are the ways in which we can acidify the urine? We can just give him substances that will change the pH of the urine, thereby increasing the excretion of the drug. Substances like sodium carbonate could do that. Substances like sodium bicarbonate, acetazolamide, potassium citrate, ascorbic acid, which is typically called vitamin C, and cranberry juice. Cranberry juice is what is shown on the screen here. So we could give him this if you could have can't afford the others. To acidify the urine and increase the excretion of codeine that he has taken. If it was the other way around, if this particular student had taken a weak acid, what we would want to do would be the opposite. We want to alkalinize the urine, and in doing so, that would increase the excretion of the weak acid. What are the ways in which we can alkalinize urine? We could give them substances like ammonium chloride, sodium phosphate, and potassium phosphate. These are substances that would change the pH of the urine and thereby increase the excretion of a weak acid. Just for you to note, these are examples of drugs that are classified as either weak acids or weak base. So we have drugs like quinine, probenecide, morphine, histamine, serotonin, and dopamine, and pentidine, all classified as basic agents, the weak base. And then we have drugs like aspirin, penicillin, methotrexate, which is an anti-neoplastic agent, indomethacin, furosemide, and thiazide diuretics, all classified as acidic agents. So in case you see any of these drugs in your questions and they're asking you question about manipulating the excretion, think about the fact that we want to either acidify the urine if it was a basic drug we're talking about, or want to alkalinize the urine if it was an acidic drug we're talking about. So how do we measure drug elimination? So the way we measure drug elimination is by the use of three major parameters. These parameters include clearance, the half-life, and then the elimination rate. The clearance talks about the volume, and it's the volume of blood or plasma or medium or excretion that is cleared of a drug in unit time. And they have different formulas for calculating clearance. The two that we tend to settle with would be clearance equal to 0.7 times the volume of distribution divided by the half-life, or we could settle with volume of distribution times the elimination rate. Typically, you're not going to be asked to calculate the clearance of drugs in your in courses, but it's just important for you to note the concept of clearance in terms of its definition and in terms of what we tend to measure. The half-life is the second parameter that measures drug elimination. The half-life deals with time, and it's the time taken for the concentration of a drug in the blood to fall to half of its original value. So think about the scenario where we are giving 100 milligram of a particular drug. The time it takes for that 100 milligram to be reduced to 50 milligram will be referred to as the half-life. We have different ways of calculating half-life, but the two major formulas we use in calculating includes half-life equal to 0.7 divided by the elimination rate, or we could use 0.7 times the volume of distribution divided by the clearance. Now, you're not going to be asked to calculate half-life using these formulas, but we can give you a case scenario where you have different doses, an original dose, and then I'll have different timelines, and they ask you what the half-life is based on that. The last measure of drug elimination is the elimination rate. The elimination rate talks about the fraction of drug that is eliminated at a given time, and the formula for calculating elimination rate is as follows: elimination rate equal to clearance over the volume of distribution, or if we want to make use of the half-life, we would say elimination rate equal to 0.7 divided by the half-life. So talking about elimination rates, we have made two major types of elimination kinetics that a drug could fall into. Drugs would either be categorized as a zero-order elimination kinetic or a first-order elimination kinetics. For zero-order kinetics, the drugs that are categorized under zero-order kinetics, usually a constant amount of these drugs are eliminated per unit time. So think about the scenario where a drug is classified as a zero-order kinetic agent, and we are given 100 milligram of the drug. If we say that the constant amount of the drug that is removed per unit time is 10 milligram, let's say if we go back every 1 hour, out of that 100 milligram, you will have 10 milligram of the drug removed. So 1 hour after, you have 90 milligram of the drug in the blood. After 2 hours, you have 80 milligram. After 3 hours, you have 70 milligram. So usually a constant amount is removed. That's what we refer to these drugs as zero-order drugs. Aside the elimination of the drug, the constant amount being eliminated, the elimination rates of the drugs tend to be constant or independent with drug concentration. Think about it. If a constant amount is being removed, then even if we increase the concentration of the dose of the drug, that constant amount is just going to be the only thing that is removed from the. So let's say we increase it from 100 milligram to 200 milligram, it's still going to be that 10 milligram that's removed per unit time. Because we increase the dose does not mean that the rate of elimination is going to increase. So we say that the rate of elimination is constant or independent to drug concentration in zero other kinetics. The half-life, on the other hand, is affected. The half-life is tends to be proportional to the drug concentration. So if we increase the drug concentration, the half-life would also be increased or affected, because we're just removing a constant amount, 10 milligrams. So if I increase it to 200 milligrams, we have more drugs present within the body, and it takes a longer time for that drug to get to half of the original concentration. So the half-life will be proportional to the drug concentration because of the constant amount that is being removed. And the reason why all this is so is because the enzymes and the transporters involved in the elimination of the drug would be saturated at a particular concentration. So once we increase the concentration beyond that particular maximum concentration, the enzyme and the transporter can only break down or remove a particular or constant amount of the drug. Hence the reason why this particular zero order kinetics is the way it is. What are examples of drugs that are classified as zero order kinetics? So the examples of drugs classified under this are very few, and we use the acronym HEPA to remember these drugs. We have drugs like heparin, drugs like ethanol. Ethanol could also be called alcohol, phenytoin, and then aspirin. These are the four major drugs that are classified as zero order drugs. For the first order kinetics, the drugs that are categorized under this particular type of elimination kinetics has constant percentage of the drug being removed per unit time. So in this scenario, think about another drug that is classified as first order kinetics. That particular drug, if 100 milligram was given, and we are stating that per unit time, per every 1 hour, 10% of the drug, or a fraction of the drug, 10% of the drug is removed per unit time per hour. What it would mean is that if you give 100 milligram of that drug now, and 1 hour after we go and check, 10% of that 100 milligram would have been removed. So 10% of 100 milligram is 10 milligram. After the 10% has been removed initially, and you go back to check a second time, so let's say we're going back to check after 2 hours, 10% of the 90 milligram that was left after the first 1 hour would also be removed. So it's going to be a constant percentage, not a constant amount that will be removed. As a result of this, elimination rate of first order kinetics tend to be proportional to drug concentration, because it's a percentage that is going to be that is removed, not an amount. So it's not a constant amount that is removed, but a constant percentage. So if I was to increase the dose by 200 into 200 milligram, so we're going from 100 to 200 milligram, because I've increased the dose to 200 milligram, that 10% that is initially removed after 1 hour, 10% of 200 milligram will be what is going to be removed if I increase the dose. So you'll be having 20 milligram be removed, not 100 milligram, once I increase the dose. So increase in drug concentration or increase in dose will lead to an increase in the elimination rate. On the other hand, the half-life will not be affected. The half-life typically tends to be constant or independent of drug concentration. And most drugs in the world tend to follow the first order kinetics. And that concludes our module on pharmacokinetics 2.